Welcome to another edition of our Focus on Facebook. My name is Hasnain Kermali, Chief Medical Officer here at St. Mary's Hospital. Each month we like to highlight one of our clinical departments and expose and demonstrate the expertise that we have here at St. Mary's Hospital and within the Waterbury market. So welcome and glad you're with us today. Today I'm joined by Dr. Alexander Carrese from physical medicine and rehab, a physician in that realm of things. Thank you very much for joining us today.
Thank you for having me.
We're going to talk a little bit about you and your specialty, what services you're able to provide, and what that means for the patients in the greater Waterbury area. So I wanted to talk about you as an individual, because your story's beautiful, like many stories are. Connecticut native, grew up in the New Haven area, but you've moved around not only the U.S., but the world.
Yes. From being like a Northeast Connecticut guy, I was born in Brooklyn, but lived here most of my life. Never thought I'd leave the Northeast. And of course, that meant that I went to North Carolina for med school, and then I went to Michigan for residency and fellowship. But I did have an opportunity during training to go to Africa. So I went to Zambia for a month, and I was able to work at the University of Lusaka. There's a hospital system based there, a teaching hospital, and train people in what I do, which is EMG nerve conductions. That's just one thing I do, but also kind of bring the PM&R to that realm of the world. A lot of neurology cases that I saw, but got the opportunity to train people and just kind of see medicine in a third world country, which was an eye-opening and fantastic experience.
Yeah, I imagine it's different medicine, but the patients are the same.
Patients are the same. The doctor-patient relationship was different. The family importance there was much different. Like, families take care of their patients mainly once the doctors and nurses leave. So a lot of people would be sleeping outside the hospital and just waiting for their family, or they would take turns in how to handle things. So things along those lines, what they had available to them, very limited in certain senses. And there's how people still got along with their normal activities of daily living, and how they just took things in stride. And unfortunately to them, the hospital is usually a sad place because people usually go there and don't come out, and that was always the hard part. But overall, fantastic people. I had a great experience there.
That's wonderful to hear. I love the dynamic of learning from other cultures. My family's from Africa as well, and so hearing work done in Africa sort of warms my heart. But just the idea of appreciating where a different culture comes in, the different styles of how they manage patients. And at the end of the day, that patient-doctor relationship is what proves to be critical. And hearing the difference in their responsiveness to the hospital or their perception of a hospital is profound. A little sad that patients ultimately go to the hospital and don't always come out. Different than what we experience here.
Oh, for sure. It was just eye-opening in all levels. I say this to any doctor, any person training, that try to do a mission trip, try to do something just to see. I think it's just a good experience to see what other people have to deal with, and then what we have available to us and what we can do to help people.
But it's a great reflection on your character as well, that you're willing to spend that extra time to go out there and do that kind of work, critical to our entire mission.
Yeah, thank you.
Thank you. Tell us about the field of pain medicine. What drew you into that field?
I have a unique experience. I was diagnosed with Carrese when I was younger. It's a rare kind of bone condition in my hip, where basically I lost blood supply to my femur, and I woke up one day, I was limping. I'm like, okay, no big deal. I have brothers. We fight all the time. No big deal. A couple days later, I'm still limping. I'm like, this really hurts, and so I go to the doctor, and instantly he's like, took an X-ray. He's like, here's crutches. Go see this guy. So it was a pretty extensive period of time. So I had basically about 7-8 surgeries since that point, all dealing with my right hip. So from a young age, I was in and out of doctor's offices. My father's a physician, but pain is just unique in every sense, and every patient has a different, pathway to how they got there to where they are, and just overall just looking for some kind of relief. So really being sensitive to that every patient's different. You got to treat them differently. Every patient's perception of pain is different. So on that end, we really have to just kind of get down to the root cause. What's happening? How can I help you? What can I offer you? And in some cases, like I will say, if this is not going to work for you, I'm not going to do it. I'm not going to do something that's not going to help you, because I don't think that's the right way to do medicine.
Sure. And I love that you are talking with your patients.
Oh yeah.
Not simply to your patients.
Yeah.
But involving them in that pathway.
Yeah, I think having them as part of the conversation in the treatment plan is key. It's one of those things, I don't know if it got lost, or it's never a way I practice, but I tell them, I'm like, this is how, this is what we can do, this is what we can offer, but like what, how aggressive do you want to be, or how conservative you want to be? And I think including them, they really understand and appreciate that. And I think that's a really just thing that I always like to do, and I think I've gotten good feedback from them so far, especially the people here.
And that's great. Love to hear that. One interesting part about St. Mary's relationship with your practice and with Dr. Patel's practice, because you're new into that practice, is that you are a group of private physicians and independent from St. Mary's, our medical group, but you're part of a bigger umbrella that we work together as a clinically integrated network. So for patients that are within St. Mary's, how do they relate to you in terms of coming back to the hospital and the relationship there?
Yeah, so we actually have a few things that we can offer for patients. We can do certain interventions in the hospital, in a hospital setting, in a surgical center, or we can do them in our office. And as best we can, we try to make it as easy for them, what they're comfortable with. There's procedures that sometimes that require a little bit more sedation, so we have ways to get that done, and that's a discussion for usually when the patient. But if we can, we try to help people as best we can, and especially having a good relationship with the doctors in the area. They know us. They know Dr. Patel. He's been here, about 20 years or so, from what I hear, what he tells me. But overall, I think it's just having a good relationship to meet with all the primaries in the area, and as a place that we know people come and get better. Generally. So
and we've had a great relationship with Dr. Patel, part of our community here. So we're glad to continue this relationship and welcoming you into the fold as well.
Yeah, no, it's been great.
So your focus, and this is a mouthful, well, a little bit, interventional spine, musculoskeletal, pain, and electrodiagnostic medicine.
Yep. There's a lot.
I leave it to you. Let's start. I guess the big. What is it really? The 30,000-foot view of that.
Really, I look at it as really anything musculoskeletal. That's the the bread and butter. So anything like that involves basically back or extremities, we kind of handle. And I mean, I can list out all the ones, but that's just going to be kind of annoying. But in terms of anything that is non-operable, so we're kind of like a non-operative orthopedic in a sense, where we handle a lot of the musculoskeletal complaints, and we have interventions, whether certain interventions that are targeted towards that. And generally, with those interventions, we use guidance. So we kind of talk about that in terms of using X-ray or fluoroscopy or ultrasound guidance too. That's the interventional MSK side of it. When it comes to the electrodiagnostics, electrodiagnostics has been around a long time, but it's really a way for me to establish if there's an injury, is there nerve damage, and that's really what I'm looking for. The easiest example is carpal tunnel. Clinically, I can diagnose carpal tunnel. You can diagnose carpal tunnel. How severe is it? Is it mild? Is it moderate? Is it severe? And I can kind of talk to patients as I do the test and say, this is where you're at. These are the options moving forward of what to do. And I think for them, it's a little bit more reassurance. Is it severe? Is it just mild? What can I do to get better? And I think having that almost immediate kind of answer is definitely helpful for patients at the time.
So what type of patient do you see? Are they coming to you with a hand that's dropped or a foot that's dropped, or is it simply, I've had this pain for a while, I don't know what I'm doing, and I kind of want to see what other options are out there for me?
I'd say both. I've seen the wrist drop. I've seen the foot drop. Sometimes I've seen hip pain, and then they've gone and seen a surgeon, and then they're like, I think it's coming from your back. So then we see those kind of patients too. So definitely a wide variety. Back pain, it's one of the most common visits for ERs, hospitals, primary cares.
Yes.
I think we see a lot of back pain. That's probably 90% of what we see overall in what we do. And I tell people, we talk about back pain. I know you can see surgeons, you can do lots of things, but even in terms of injections, there's multiple types of injections we can do or can offer. But it really comes down to what is the source of the pain. That's what we're always trying to find first. So whenever people come to me, generally, I'm like, okay, let's figure out where this is coming from. And then with testing, MRIs, EMG, whatever we can do, and then we can talk about a treatment plan from there.
So it's interesting because you're talking about figuring out where the pain is coming from, which to a simple mind would be like, well, that's a simple thing.
Yeah.
If my knee hurts, it's clearly my knee, right? But I don't think that's always the case.
I wish it were that simple.
Yeah.
The joke is, it's always like, find the root cause, but like, what is causing pain? Like, what are the pain generators? And even with some of the injections we do, sometimes, they're not only therapeutic, but they're diagnostic. So if we can even turn off that pain signal or whatever's causing the pain, even for a short period of time, it gives me a lot of information. And now if it didn't work, okay, we got to, reset. But in general, finding the source, and especially, something simple as knee pain, is it your knee, or is it your hips or your back? And that's the great question. And that's really where we do a really extensive neuromuscular exam on every single patient to really kind of get down to that root cause.
Yeah, and so let's talk about the relationship, or what a patient can expect when they come into your office for this sort of knee, back, hip evaluation. Is it simply, here's a prescription, or is it more than that?
It's definitely more than that.
Yeah.
I think the funny thing is, like, especially for someone of a training, I've done extensive neuromuscular exams, and especially like reflexes. Like, I've done reflexes on patients who are like, I haven't had this done since I was a kid, or if they can even remember. But it's pretty extensive. I mean, we always book time, and it doesn't matter how long or how short it is. I talk to them, and I try to get, okay, when did this start? The basics, but really putting our hands on them, really checking their strength, checking their reflexes, making sure we're ruling out all the major things like anybody else would, but really kind of getting a feel for it. So a patient walks in, and usually they walk out with a better understanding, but generally I'm going to check every muscle that I need to, or every joint above and below that. If it's a knee, a hip, I check the hip and ankle just to make sure.
Sure.
Because I want to be thorough, and I want to make sure that we kind of, target what we're focusing on, and as I mentioned before, the treatment plan moving forward and what to expect.
And it's interesting, because I know in all of our training, when we hear about joint pain, there is the adage, well, you're checking the joint above and you're checking the joint below.
Yeah.
Really trying to hone in on that, but that's your specialty.
Yeah.
That's what you're trained to do.
Yes.
Find the pain and then treat the pain.
Yeah.
So let's talk about how you go about treating the pain, because I found that fascinating.
Oh, yeah. So there's, like I mentioned, there's a lot of different types of things we can do. As a clinic, we try to focus on interventions or injection-based therapy, especially with the time where, opioids are such a stigma of what's going on. I mean, yes, do opioids have a place in medicine? I think they do.
Sure.
But under a very controlled, very, regimented, I guess regimen, but very strict regimen. Have I handled opioids and I prescribed them? Yes. Is it something I do like primarily? No. I try to find other ways to do it. They do help in certain cases, especially with acute pain. Long term, it's something I prefer patients not to be on, and trying to wean them off is always a goal of ours if patients are on them. But I think if you have the right doctor and they're watching you and they're making sure everything is okay, I think they do have a place. But is that for everybody? No. But is it needed sometimes? In some cases, yes, it is. And I have no issue saying that. But being safe is really the key. I mean, with opioid deaths and everything that has happened, and just the way things were, years ago before I probably was in med school. I mean, we're at such a better standard now, and I think the standards have really been raised. And I think that as a clinic, we do the same things. We follow the standards, the guidelines that are available to us, and that we make sure that everyone's being treated properly and not being over-treated or over-medicated in a sense.
Yeah, and as a hospital physician back in the day, it was very encouraging to see the steps that Connecticut took to ensure we were managing with the opioid crisis here. Yeah. For example, going onto the registry when we're prescribing opioids,
every time,
limiting the amount of opioids that we're able to prescribe, at least from the hospital perspective. We only were able to give a certain number of days. And those are steps just to combat a serious issue that's claiming and continues to claim, unfortunately, a lot of lives, particularly now with the introduction of adulterated opioids that are out there in the communities, and clearly something that we are dealing with here in Waterbury. But it's good to know that you're not just focused on the pain medicines, but actually on technologies and interventions that target the pain. Let's talk about that a little bit.
Yeah, I would say medicines, you're usually like, those ones are usually the last thing I go to if I ever do get to them. But yeah, in terms of targeting pain and injections, generally, we use a combination of just like I say liquid steroid. Everyone thinks cortisone, but cortisone shots would be like the easy way, the layman term to say it. But there are different types of steroids that we can use. We have low dose, we have high dose, and then really the focus is guidance, using guidance for this. We want to make sure we hit the target. I think any physician that does what we do in interventional or ultrasound guided, they have to be guided procedures, just to make sure. If someone's going to allow me to, I hate to say it like this, but poke them with a needle, I want to make sure, one, I got the right spot, and two, it's safe. That's always, paramount, safe. And especially the training you do, especially in interventional, I mean, you do it for a year for a reason, because it's not easy. I couldn't come out of residency just doing this. I needed the extra year of training, so that's what I did. And that training, especially the first month, was strictly like, you're going to sit there and watch what we do, because this is serious. I mean, these are people's backs or necks that we do, and people get very nervous about it, and I try to ease them into it, but I understand. I mean, I've been a patient before, and even as a doctor, I'm like, I get nervous going to the doctor still, and I do, and I mean, I've had surgery before, and there's times I'm like, man, like I can understand how nervous it is on being on the other side, and I try to remember that at the end of the day too, that these are patients, and a lot of them haven't had this experience that I've had, or whatever. So I try to ease them into it and just talk it through with them, and I explain the procedure. But generally, the main thing is being safe and targeting the area to make sure that we, get the right spot.
And your perspective, bringing in your own history as a patient, and how then your understanding, the empathy of that relationship even becomes greater.
Oh yeah, I don't mind using myself as an example anytime, and like I say, I understand. Like, I mentioned a little brief part of the story, but when I said I had 8 surgeries, but it ended up having a hip replacement at 24. So I mean, and everyone looks at me like, you're too young. I'm like, I was too young, but it was literally the only option at that time. But I talk with them and I tell them, I'm like, this is, everyone's different. That's why when everyone walks in and they tell me this hurts, and I'm like, well, I believe you. I can't explain half the things I went through, but I mean, that happened to me. So I'm not going to sit there and discount anyone's pain at any point in time. But I think talking with them, especially saying, and there's times where I'm like, I don't know what you're going through because I haven't had that before. And I will, but I'm like, but from what I've heard, it hurts. And I understand that. So then I try to, reassure them that it's okay. If you're having pain or this is not normal, it's not, and that's where my role is to kind of help them understand, one, and then two, try to best treat them.
So it's a working relationship.
Oh yeah,
an educational piece.
Yeah,
and then the therapy. Let's talk a little bit. What was intriguing to me was the electrodiagnostic medicine. Yeah. I want to hear more about electrodiagnostic medicine.
I can go into details. I was trained by a really great doctor, Dr. Andary. He was at one point the president of the ANEM, which is the electrodiagnostic boards, basically. But very good doctor. So electrodiagnostics is a great useful tool to look really. Mostly, I'm going to say 95% of the time, looks at things outside of your brain and spinal cord, so anything peripheral. So I mentioned, carpal tunnel. That's our bread and butter. One of the things we do most times. Radiculopathy, so a pinched nerve in your neck and your back. We can help diagnose, one, if it's there, two, how severe it is. Is it very severe? Is it mild? There's other things we can certainly do with it, but those are the main things I do it for. The more complicated cases, when I was training, like ALS is one that we used it for as well. Okay. So yeah, it's an extension of your physical exam and history. So everything, you shouldn't be any surprises on that test, but it helps me grade it and give at least an idea of like where they are at. Is it in terms of a foot drop? Okay, how long ago was the foot drop? Okay, is there any motor units there, or is there still something there where you can get recovery back, and I can kind of help them, hopefully give good news. That's always the goal, is to give them good news.
Yeah.
So, but it's a great test. I love doing it, and I have time with them. It's usually about 20 to 40 minutes, and I really get to know them, and especially when you're, shocking them and using a needle to stab them to check certain things, they have to trust you. So they, usually, but it's really good for the doctor-patient relationship, and I usually have a good conversation as to what's going on.
So and it's more than simply, I've got a pinched nerve, which they sometimes come to, I imagine, with a report or a disc. It says, hey, I've got a pinched nerve, we need to take care of this.
Yeah.
You're trying to figure out, well, okay, you've had a pinched nerve.
Yeah.
How much of that muscle is affected by that nerve, and then what can you do to get function back?
Right, and especially I tell people all the time, because the MRIs will say a lot of things. Imaging, as you know, can say a lot of things. I don't treat images, I treat patients. So I mean, even like when patients say like, well, the MRI didn't show anything, I'm like, that's you laying down, and that's just an image in time. This is another piece of the puzzle. These are all pieces of the puzzle. We don't just basically treat off one thing. I think that's not a way to treat or practice medicine.
Sure,
we have to put the whole picture into perspective, and as I mentioned, it's an extension of the history and physical exam, so clinically I will treat you, but these are other tests to help me kind of rule in and rule out certain things, and that's what we're looking for.
And I think that's a key point there. The imaging doesn't always show what we're looking for. We see that often in the hospital. Somebody will come in with something and we'll do an image and it doesn't show that there's a problem. But just because the problem isn't there, sometimes the underlying factors might still be present. I think of people, for example, who've had TIAs or transient ischemic attacks compared to strokes. Sort of like you're going to have one some point in time. We have to figure out the factors that are leading up to it and take care of it. And the MRI is negative for a stroke, which is good.
Yeah, which is good. I mean,
but then you go through the other pieces, kind of similar to what, different, but similar, where maybe my back doesn't show any pinched nerve, but I'm still having pain or down my arm or something. Yeah. And these types of tests can help better figure those pieces out.
Yeah, and I tell people, I mean, probably the more common thing I see, as I know, is based how they're presenting, is something's irritated, and we just need to figure that out. But if it's not causing nerve damage, and as my my main mentor would say, you don't want what we're looking for because you don't want nerve damage. He's like, believe me, if you had a choice between one or the other, you don't want it. So it's sometimes it's reassurance too, but also to trying to at least help establish diagnosis or rule out the major diagnoses that could be causing these problems.
Sure. So let's talk about, I like to think about the future a little bit as well. We talk about nerve damage and we hear about people who slowly gain recovery. But can you give us a thought about neuroregeneration?
Yeah.
And that idea and theories in medicine?
That's the hottest topic in our world right now. In terms of is it platelet-rich plasma, or we're talking about stem cell. I do know there's being tons of research done. There's new articles every single month, and trying to be on top of them at what's best. I think the biggest drawback right now is that most of this is usually a cash-based kind of thing. Insurances haven't quite got up to it. The studies, there are good studies, and there's also studies that have shown maybe it isn't working as much as we want to, but I know actively insurance companies are trying to figure this out, and other companies are trying to find anything that can help, especially I think as a role, getting away from more of the steroid-based injections to go more to this natural platelet-rich, using your own blood, spinning it down, using your platelets, things. I think that's the future of medicine, but I think it's an ongoing thing. I think it's getting there. It's not quite there yet, and I think the insurance thing is a big thing, because especially you talk to patients, they're like, "Oh, I would like to try that." I'm like, "Okay, but it's not covered." So it's we offer it, but we have to be mindful of cost and everything like that. It's something as the person who trained me in interventional spine, he's like, "I guarantee you in 20 years you probably will never use a steroid again." That's the way he sees it's going, and he's been around long enough to see the evolution of what we do. Yeah. But which I truly believe, and I think that will be the future. I think actively that's like probably the holy grail at this moment, at least in my world, of pain medicine.
And then I mean, something you mentioned about using the body's own capabilities, platelet-rich therapies. What's the role of exercise in general for some of these recovery plans?
Honestly, without physical therapy and exercise, I'd say our job is very difficult. And then so generally how I approach patients too, especially if they haven't done physical therapy, I'm like, well, I usually like to start there because in most cases it's just you need someone to train you to do the right things. And I know, and I say pain didn't get there overnight. In some cases it has. If you fractured your bone, certainly that got there. But especially back pain that people have had it for years, I'm like, it didn't get there overnight, and it's going to go away. I mean, being diligent. Exercise is medicine. I think movement is medicine. Generally, the patients I treat, are hurting to a point where they aren't able to do exercise. So I'm like, all right, well, my role is get you feeling better, and then I want you in therapy. I think that's really a key, and that's really the long-term answer as much as I do. And I always say this, especially for back arthritis, I can't fix arthritis. No one can at this moment, but can I get you feeling better enough where you can go to therapy and strengthen the muscles around it? Absolutely. Shoulders and knees, I mean, again, look above and below, strengthen those muscles to help. Sure. Plenty of patients I know have torn rotator cuff muscles. What do? Therapy. I mean, if you don't want surgery, I mean, your options are limited, but I mean, therapy will help at least mitigate. Now, do I want you to be in therapy all the time? No. Right. But I want you, a good at-home exercise program. And I will say, I mean, even for myself, like yes, I need to do my exercises. I understand that, but it's a commitment. And I think if people that truly want to get better are committed to that and they do well, but I'm never going to, bash exercise. We have other ways we talk about it. Aqua therapy is one that we utilize in the area too.
Sure.
We're getting people in a pool, takes the pressure off their bodies and their legs.
Great.
But anything we can do to get them moving, I'm always for. I really think that's the key.
And one of my orthopedist trainers, back when I was doing orthopedic rotation, he had mentioned motion is lotion, which I love in general. And one of my heroes, a lady that I worked out with back a few years ago, she had actually suffered a traumatic spine injury. And had lost a degree of function.
Yeah.
And yet there she is at the CrossFit, every 2-3 days a week working, and continues to defy the expectations because she continues to move with purpose. And it was astounding to see that. She's one of my personal heroes. Because if she can do it, then I can do it, and a lot of people can do it.
I've gotten into the CrossFit world before. I was a trainer at one point in time before medical school, but just seeing what people can do, and especially just simple things. And I always tell people, be safe. I mean, people can get injured lifting. I've seen that too. Always be safe. This is where I like the physical therapy aspect, because you have someone that will literally train you how to do it correctly.
Yes.
I mean, you can't always have someone watching over you, but you need to know what you're doing, because I mean, as easily as I could say, oh, I can do that on my own, I could, or I can go to therapy and get the right exercises to do on my own. And when I have done that, it's been beneficial. I mean, I've had a lot of therapy with my hip, and I understand, but without physical therapy, occupational therapy, and in other cases, speech therapy, I mean, those are some of our backbone. Those are the things that really help people, kind of not only get better, but also if they have to adjust, how do they adjust properly without hurting themselves even more? So
yeah, and it's true. The physical therapy aspect of it, the little nuggets they can provide.
Oh yeah.
Till today, I use them when it's my shoulder or when it's my legs or whatever. Just that small little, do this first, get this engaged, and then you'll be good to go.
Yeah, I mean, so many times when I go to the gym, there's a few exercises I always do, and because I told myself there's certain surgeries I never want. Having worked in a physical therapy clinic prior to med school, shoulder was one of them. I was like, all right, I'm always going to do my shoulder exercises just to be sure. But there's always those little things that just to keep my back, my hip healthy. Like I understand. I mean, there's things that are going to happen, which I understand. Also being smart, about it, but proper technique and just making sure that you're constantly moving, I think is the way to go.
And I want to reiterate, let's listen to our bodies when we're out there, particularly when we're talking about like shoveling snow, moving heavy things, being careful on ice. I think those are all strategies. We're talking about things like penguin walking when you're walking on ice, and being aware of how heavy snow can be, taking it easy and making sure we're using appropriate technique.
No, absolutely.
Because we're not all 20 anymore, and even as 20-year-olds, it's a challenge.
It is a challenge, especially snow. That was something in training that we were always, board-wise, always talked about. But shoveling snow, it actually, in terms of metabolic equivalence, is pretty high. Yeah. So it's actually a common cause of heart attacks when you do it. So it's one of those things that you think you can do it, but ease into it. Don't overexert yourself. If you have to rest, listen to your body. And patients always ask me, like, what if this hurts? I'm like, don't do it. Like, if it hurts, don't do it. Find ways to get around it. But then again, that goes back to like, this is where someone else can kind of help you guide it. But I always say, if as long as you're not hurting, that's fine. But if it hurts, stop or readjust. You have to not be in pain, because your body doesn't want to be in pain for sure.
Yeah. So let's give one last little nugget to our viewers in terms of what's something or what steps can they take, simple day-to-day steps, and maybe a first line that you would say, hey, if this hurts, maybe try this first if it's safe.
Yeah. Thinking about that, generally I tell patients too, especially if a new complaint comes up, if they're already established with me, if their back pain returns, I'm like, usually give it a day or two. Just see, did you sleep wrong? Did you step wrong? Think about what you did and try to kind of fix that problem. If it's still going on for a couple days, generally I say, always see your primary first. They're the first lines. They are fantastic. I can't, say how much primaries are helpful. And always rule out the big things. Whether it's an X-ray. Or just whatever they kind of deem X-ray, blood work, whatever they think it is. Generally for us, it always is beneficial, especially a specialist, is that if they got in a workup or if they've gone to physical therapy first, because more often than not, this can be handled just with a couple sessions of physical therapy, a good home exercise program. There's also, we're in the digital age, there's plenty of YouTube channels, on there too. Just certain things to see that can help you. Medications, I always like, Motrin, Tylenol, things like that, just to kind of see. If it's still progressing and going on, that's when you start to get looked at. Usually if things have been lasting 3 days or over a week, then I'm like, you really need to get checked out. Something happened, something's different. If it's acute pain, obviously use your best judgment. Go to the urgent care, go to your primary as early as you can. But I always kind of tell people, give it a few days, because most people can sleep wrong, wake up with pain, and this happens to me commonly. They walk in with pain, and 3 weeks later they're like, I didn't do anything, but the pain's gone. And I'm like, that will happen. I can't explain it, but generally always try to just do the little things first, the things that you just are easy for you to do.
Sure.
I'm not in their home with them, but there's certain things they can stretch out. They can do some core exercises. I think those are always the first line things that anyone should do before they see us. Obviously, some of the patients I see have been down the line and have gone to the specialist and get referred to us, which is understandable. But for just an acute issue, if it's not too serious, I think that's something we can manage on the front line first.
And I love that. Simple things first.
Yeah.
Stretching, a little bit of movement.
Yeah.
Simple medicines if you need them, Tylenol, Motrin.
Yeah.
And start there first.
Yeah.
And then move from there.
Yeah, because especially the primaries are great. Like I mentioned, frontline, but ruling out the major things. That's what we always try to rule out. And when you go to the ED, what are you ruling out? The major things that can cause these pains. So if you can save that, or just by a few simple things, start there. But then again, we're always there if you need us. Or as a recommendation too. Sure. We're always available to help. But I always say just common things being common. This is maybe a strain.
Yeah.
It will get better over time. Just do what you can. So,
great. Yeah. Well, thank you very much, Alex.
No
really
problem.
Appreciate it.
Thank you very much.
Have
for
a great
having me.
day, and thank you, everybody. We'll see you next time.